Greetings. Thank you for joining us on this special edition of Health Diary. My name is Gladys Gashanjan. We're coming to you live from the Westwood Hotel here in Nairobi. As you know, that hashtag is Cancer Dialogue, even as we try to understand this scourge that has come right in our faces with all the statistics that are being associated to them. And of course, we cannot ignore the fact that 2019, July, to be specific, goes down in history as 1 month that we shall remember after 3 prominent people in society succumbed to cancer. But the truth of the matter is, cancer has been with us. Why is it ravaging us now more than before? Well, we have the experts in this field to talk about it. But apart from experts, there are those who are living the reality of this. We're talking about survivors, and we're also talking about caregivers who are walking this path with them, who will be telling us about their experiences. Well, to kick us off now on this discussion with me on the main panel, we have Dr. Andrew Odhiambo. He is a medical oncologist. Thank you so much for joining us. Next to him is Dr. Jonah Manjari. He is the CEO from KEMSA. Thank you for your time. And then we have Dr. Judith Otele. She is from the NHIF. Thank you for your time. And we have David Makombi, who is the Vice Chair of the National NCD Alliance. Yes, and you will be introducing yourself more and what you represent, but really representing the civil society. Now, these will be the main speakers, but as I said, this is a town hall discussion. There's so many players in this discussion with us here, and they'll also be giving their input on the same. And I'll start off with Dr. Andrew, and I think this falls squarely in your laps because you are the medical oncologist, and there are some of your colleagues on set with us. Why are we hearing cancer more now than ever before? Has something changed, or are we more aware of it?
Thank you very much for that question, and allow me to answer you with 4 reasons. I used to think there are 3 reasons before, but I think there's a 4th one that I've added to it. So 1, I think the population of the nation has increased. We are now plus 50 million. I don't know the next census, the results will come out, it might be 60. But there's many more Kenyans living longer. You know, HIV has been controlled, so we are living longer and we are seeing more cancers. Number 2, we have developed the capacity to diagnose cancer better in terms of the pathology team who look at the slides and the equipment, the scans that have now been rolled out into the country, and therefore we are able to make more diagnoses. So you'll see more numbers coming up. And then the obvious reason of adapting a Western lifestyle. You know, we are all in Ubers and borders. We are not walking as we used to. We are not engaging in physical activity as we used to. We are consuming more alcohol. We are smoking more. And so that lifestyle of bad eating and everything leads to more cancer. Number 4, which I think has really contributed to also a lot of the cancer vibe that we are getting, is there's a lot of dissemination of information. You know, in the late 90s, in the early 2000s, we didn't have Facebook, there was no WhatsApp, there was no mode of you knowing that even your neighbor has cancer. But right now, if your estate block, you know, somebody has cancer, it's there in the group, you're contributing, it's on Facebook, it's on everywhere, you're seeing this cancer message going around. So it is because it is more visible now, we get the sense of feeling that there's too much cancer, you know, there. My friends who treat diabetes and hypertension are complaining that they're not getting a lot of limelight. Yet diabetes is probably 5 times more common than cancer. High blood pressure is still very common. So I think those 4 reasons, I don't know if Fred wants to add something, but yes. I think in a nutshell, that's really contributing to a lot of the rise of cancer cases that we're seeing.
Okay, and as you rightfully mentioned, we have Dr. Fred Chite, who is actually all the way from Eldoret. If we can get that microphone to him, and definitely Mr. Chite deals a lot with the machinery. And most often than not, as you're saying, a lot has to do with the food, our change of lifestyle and all that. It has been said cancer is an urban issue, but the truth of the matter is it cuts across both. If we can get the microphone to Dr. Chite so that he can give us a perspective of how it is looking across both.
Yeah, so thank you so much for that. I totally agree with Andrew, but in addition to that, there is unknown. So remember, cancer is not one disease. cancer is more than 200 diseases.
Yes.
And each cancer has a different risk factor and all that. And even as we work in Mashinani, there are some places we are finding some specific cancers are more prevalent than others. And our question ends up being, why? So although it may be just the numbers, but also the numbers of those affected vis-a-vis the general population is a little higher for some of the cancers. So one of the main things that we plan to do and that we've been engaging in is working very closely with Ancorir in terms of cancer registration and also NCI to ensure that we can really have a very strong, robust, both hospital-based and population-based cancer registries. Then it gives us very better estimates of what's going on, and then we can do a lot more surveillance then.
Okay, and Anne Korir is definitely here with us, and she plays a very big role in as far as giving us these statistics that we are referring to. And as I mentioned, Anne Korir is the head of the cancer registry at Kemri. Now, the numbers that came out is that over 40 new screenings and people living with cancer, and of course, over 33 deaths per year. Why are we seeing these numbers? When you were doing that research, what came up?
So thank you so much. As the earlier speakers have mentioned, all these factors come into play, and that's the reason why we are seeing a lot of cancer. So these are statistics for Kenya. Of course, we have data across the world. And if you look at globally, we see cancer is also prevalent in other places. We have, I think in the last report that was released, more than 18 million cases are diagnosed globally. And in Kenya, we diagnose 48,000 cases of cancer per year. And about of that, we lose 33,000 cases. And when you break it down into which cancer, as Dr. Chite mentioned, cancer is not one disease. It's so many diseases combined. We find that the most prevalent ones are the breast and cervical cancer among women. And for men, we have prostate cancer and we have cancer of esophagus. So breast and cervix, which I really want to emphasize, is killing a lot of our women. And although it is happening also globally, like breast cancer is also common globally, the differences we see with our cases is that these are younger premenopausal women compared to, developed countries where they are older women. But in our data, we are seeing much younger women being diagnosed with cancer. These are women who are still highly productive in society. These are young women, mothers who are growing up their families. They are contributing economically to the country. So when we lose a mother like that, it really affects our entire society. So these are the kind of statistics we are seeing. Cervical cancer as well. In fact, when you look at the deaths, in terms of the deaths alone, esophageal cancer is leading. Cancer of esophagus. We normally call it throat cancer, I think in the layman language. And we know what are the predisposing factors to esophageal cancer. A lot of alcohol and smoking and many other factors are associated. And then cervical cancer. Cervical cancer, again, we know what the risk factors are, and this is killing a lot of our women. And as I said, these are young women who are dying every single day. Among the deaths, if you look at these 33,000 and you break it down, we are losing more than 90 people per day to cancer. So that is really worrying.
Wow. Yeah. And we'll be looking and referencing to those numbers even as we have this conversation. I'll throw this to Judith Otele from NHIF. We're seeing more cases of cancer. You who sits at where the claims are made and you can actually put the numbers to the conditions, has this spiked with time?
Thank you. Yeah. Cancer diagnosis has spiked with time, and the number of claims we are processing are increasing every month, probably because of more awareness about the cover that NHIF is giving to the cancer patients, and again because of the prevalence. The cancer disease has become, as Anne is saying, so prevalent, so we are seeing a lot more of claims arising from cancer diagnosis and treatment within NHIF, yes.
Okay, now, Makomi, this is something that has become part and parcel with us. We are not only seeing patients, we are talking about caregivers. All these have come together to bring together associations like KENCO, where it shows the burden and the prevalence of cancer. How does that look like, and what has built up to this coming from those that are living this reality?
Yes, certainly, with the increasing numbers that we are seeing, we're happy that the civil society, ordinary men and women, have also come up to say they must do something about it. You don't have to be a healthcare professional, and the appreciation that each one of us has a role to play. In fact, in terms of awareness and the question that you asked Dr. Odhiambo, part of the reason we are hearing so much cancer in the media, in the churches, in various communities, it's actually the work of civil society organizations like KENCO and others under that umbrella, just creating awareness and ensuring that the cancer debate, the cancer conversations don't go away. Remember, majority of the organizations also work directly with survivors, the people affected, and caregivers. There are patients who will be treated in various hospitals, but they end up in the communities. And the communities must mobilize the resources either to fundraise and cater for treatment. And of course, that's a heavy burden. And that's why the civil society voice is critical to this conversation to ensure that our families don't suffer undue financial burden, and of course that the right messages about cancer go out there. Again, we are the voice of the community in terms of pushing for resource allocation. We can say many things that probably the oncologists will not, facing our registrators or our MPs and providers to say we need to get enough resources to address the cancer problem across the country.
And definitely we'll be talking about more of what and how those gaps in the system need to be addressed. I'll bring in Dr. Mandari. And I mean, KEMSA, Kenya Medical Supplies Authority, is also a critical player in the conversation of cancer, because when we talk about treatment and management of cancer, the drugs and equipment that are needed to make sure this is a reality are critical. On your end, are you feeling the pressure to be able to provide for the need that is coming across?
Yeah, thank you. KEMSA has continued to live to its mandate of procuring, warehousing, and distribution of medical commodities. For a long time, KEMSA has been procuring only essential medicines, but the pressure is on to procure other commodities, especially to address non-communicable diseases and cancer in particular. And more so, as we do this, newer molecules are coming in. The doctors are prescribing new molecules, and they're putting pressure for us to purchase these commodities. The good thing is that we are working with manufacturers to address this issue of the prices so that we can negotiate. We are working with them to give us very good generic molecules. And at the same time, we are engaging with the national government, the National Ministry of Health, and other stakeholders so that we can come up with a comprehensive list. We've done the first priority of all the products that are required. We are now compiling the second priority, and soon we'll do also the third priority, as dictated by the clinicians. We always, come to the need of the users, and they have to give us what they need for us to supply. We say we do, we do comply to whatever they need, but they need to do it in time. That's why we are working a lot with the stakeholders for forecasting and quantification, because I need to know how many products are required, in which quantities, and what are the strengths, so that when I bring these commodities in the country, we will enjoy what we call economies of scale, and we'll be purchasing in bulk. So we are experiencing the pressure, yes.
Okay. All right. Now, Dr. Odhiambo and Dr. Chita here definitely touched on the fact that we, and Korea has also mentioned, we are seeing a younger face associated to cancer. And a lot of it is a lifestyle change. What we are eating, we've changed our ways. And I'd like to bring in the representation from the government, and this would be Dr. Makasi, if we can get a microphone to her. I mean, you are tasked to ensure that we look at the preventative diagnosis and, of course, everything to do with cancer, and make sure that we contain this scourge. The question here is, when we talk about the base of cancer, what is spiking this more than before? Why younger and younger people? Do we have a problem with the microphone? Okay. I guess we can share this.
So
we have been comparing the statistics we have with that of other countries, especially like those who have good statistics like in Europe and the UK, and it is clear that it is clear that the younger populations, especially for breast cancer and cervical cancer, are being affected by cancer. Perhaps for cervical cancer, we would say that this could be contributed by the fact that we have a higher prevalence of HIV within our population. So you find that compared to other countries, our population for HIV burden is a little higher, and so this might contribute also to patients getting cervical cancer earlier, also because they would tend to start, we tend to start having sexual relations earlier within our population compared to the developed countries. So I think in a nutshell, that's what I would say would perhaps insinuate why we are having the high younger population. Yeah.
Thank you. First of all, thank you for having me. I would say the first thing I need to note is that proportionately or comparatively, women have a higher burden than men, because if you look at the numbers, the total number of cases, there are more cases among women compared to men. But I would probably say I would link it to our overall situation that most of the diagnosis that is being, most of the cases that are being diagnosed are coming in fairly, advanced stages. So, in terms of treatment outcomes, that becomes, that becomes a challenge. So that's why we are seeing, the proportion between number of cases and number of deaths, the deaths being, what you call the ratio between new cases and deaths, almost about 70%. But more, I think the other thing that probably it looks like women. And actually, no, it's that's actually the position. That's one of the reasons why we are seeing women having more of the deaths, is again because of the profile of our cases. When you look at our top 5 cases, the top 2, breast cancer and cervical cancer, actually sort of like account for almost 25% of all our cases. So breast cancer, again, being heavily, being like 99% is in women. Cervical cancer only in women. So I think probably that dimension also, gives that picture that more cases and more deaths are being seen in women than men, just because the most common cases, the most common cancer in this country are women. Yes,
okay,
yes,
but
yes,
it
yes,
also
yes.
brings a very interesting twist to this, because when we think about our health-seeking behavior, men are worse, women are better. And I'd like the microphone to actually come to Dr. Anthony Nderito, radiation oncologist from the Kenyatta National Hospital. When you think about, we know Kenyatta National Hospital is associated with the long lines of patients that come to you either for diagnostics or for treatment. When you think about those that come through your doors, who do you see more, men or women?
Usually, thank you for the question. Usually the women will be more, and that is because of, first of all, the health-seeking behavior. You'll find most men will come late. Then the other thing to note about women is that they seek even other health care more than men. And that will bring them to hospital, and they go more for screening. If you call for screening for men, they will rarely come. That contributes a lot. Okay. The other thing, the numbers we see in Kenyatta, of course, the numbers are high. We see about more than 4,000 new cases every year. But the other thing to note about these cases that we see, 70 to 80% of them come when they are already advanced, meaning we are talking of cases that are not curable. And that brings in the what the government is doing in terms of screening and early diagnosis. Then after that is that we need to also strengthen the palliative care to take care of these patients. And if we diagnose them early, that also means that we need to improve our health care so that we are able to cater for these patients, because there is no point in diagnosing cancer that you're not treating. So you have to strengthen the chain all the way up to survivorship, palliative care, and the cases that you diagnose, you need to be able to cater for these patients.
Okay, I'm glad you touched on the National Cancer Screening Guidelines, and I'll bring this back to Dr. Odhiambo. The goal of screening is to isolate seemingly asymptomatic individuals in the community who have abnormalities that indicate they could have precancerous conditions. Now, that is for those that are in the medical world. To the layman is, the faster I come to the doctor, the faster we get to catch cancer and treat it accordingly. And this, as you mentioned earlier, is one of the reasons why we're seeing more people succumbing to the cancer. What should be done? What is the ideal situation in helping all and sundry get the right and timely diagnosis?
Thank you for that question, Gladys. So there are 4 main cancers that we need to focus on in terms of screening. And you're correct by saying screening means you're doing a test to look for cancer or early signs of cancer in somebody who is not sick. So no symptoms, somebody who's just okay, going to work, they should go to hospital to be checked for these 4 cancers. That is breast cancer, cervical cancer, colon cancer, and in specific situations, prostate cancer. Now, for all the other types of cancers that are left, we don't have very effective ways to screen for them and very accurate ways to screen for them in our local setup, and those are things we have put in the screening guidelines. So what we emphasize in general is for early warning signs to be identified. And for example, I'll give you a very good example of stomach cancer, for example. Stomach cancer, when it is starting to grow, will behave or imitate very common medical conditions. You talk about H. pylori and amoeba and the whole brucellosis spectrum. That's how you'll come to hospital. Vague symptoms, my stomach is rumbling, I have acidity, and even the doctor sat in front of you will not know the difference between that and cancer. And probably those ailments are more common than the cancer itself. So what should raise an alarm is the repeated nature of these similar symptoms. That should raise a bell so that that particular individual can be sent to a higher level facility where diagnosis can be done. Now, and that's something both Fred and I are very passionate about. It's referral systems. Sometimes the doctor doesn't know what to do, the patient doesn't know what to do, the patient is frustrated, the patient will change hospitals and keep saying, this hospital never found this. You go somewhere, change the story a little bit, get the same medication, so you keep going round and round and round, and before actually you sit in front of somebody who knows what's going on, the situation is late. That problem exists both in public facilities and even in private facilities. So the referral networks and systems and how healthcare referral is done in this country needs a complete overhaul. It needs to be changed. We're not reinventing the wheel. We can just borrow what the Scandinavian countries are doing so that a highly specialized, maybe orthopedic surgeon in a level 6 hospital is not treating simple arthritis. He's treating the more complex, things. But those referrals don't get to him, so he'll have to end up treating very other useless conditions, to be competent. So early referral is very important. Early warning signs need to be identified. And for those cancers which we have effective screening methods locally, breast, cervix, colon, and prostate, let the Kenyans present themselves to hospitals so that they can be screened for those cancers.
I think we can all agree when it comes to the treatment and management of cancer is a race against time, literally. And I would like to bring in a cancer survivor, Sally Kwenda, if we can get that microphone to her. She is at the back. She actually has survived colon, rectum, and cervical cancers. So really, we are glad that you could join us and give us your experience on the same. Has the microphone gotten to Sally so far? Has it? Okay, so Sally,
Yes.
I'd like you to give us an idea of how the diagnosis was done. Was it something that you went because you had some certain symptoms, as Dr. is saying, or was it found as they were treating something else?
Actually, when it started with the cervical cancer, I didn't have any symptoms at all. It was just in the office, people were being screened, so I said, why not? And I was told that I had cervical cancer stage 2, but I didn't have any symptoms at all. Yeah, and that's why I'm a patient advocate now, and I always say that no woman should die of cervical cancer because it can be easily detectable, and it's actually preventable. And then after, that was in 2007, and then after 3 years, I was being followed so closely. The cancer, again, I got a recurrence now, but in the colon. So 50 centimeters of my colon was cut, but the cancer spread to the rectum. So in about a year. And I must say that when the diagnosis was done, the way the news was given to me wasn't so pleasing, wasn't so, I don't know how to call it.
Not sensitive?
But it was very rough.
Yeah.
Like, you have cancer, so we have to do total hysterectomy. And that time I'd already lost 2 babies. So I expected at least some kind of counseling or someone to talk to me and tell me what this means. What is total hysterectomy for a lay person? I didn't know that it was removal of my uterus and everything that came with that. But it was like urgent, we have to do this because otherwise the cancer will spread. So I wasn't really prepared the way I expected, and I would wish that if also surgeons, oncologists would also work closely with nurses and counselors to talk to these patients, or if I would have seen someone else who's gone through it and I'm being told you're not alone in this and this other person has survived, that would be great. And can I say something on data, please?
On the data?
On the data on cancer. We have a lot of data on how many people are dying every day. Like, for example, we are being told 9 women are dying every day from cervical cancer. But they are not also saying that someone like Sally and others have survived. Do we have data on survivorship? Because that will really encourage people that cancer is not a death sentence. Otherwise, if we don't do that, people will just know that you get cancer, you're dying.
Okay, a very, very good point to put across, and that's why we are not only having this conversation, but to put the information out there that there's a lot we can learn from each other, and also put cancer, or control it if we cannot stop it, at least control it. And before we go to break, I'd like to bring in Dr. Jane Wakahe. She's seated at the extreme end, and she is a gynecologist, obstetrician, and a reproductive health expert. She has been treating cervical cancer for over 30 years now. And Daktari, when you listen to Sally, I'm sure her story is not unique in as far as how you diagnose cervical cancer, which is the second killer among women. And what would be your challenge to patients in as far as what to look for and how fast they should get to the doctor for the right diagnosis?
She has a common story about cancer cervix. The good thing about it is that it is preventable. And that's what I would want everybody to take home, that no woman ever needs to die from cancer cervix. It takes about 10 to 20 years for the changes of the cervix to change from being normal to being cancer. And all we need to do is screen. The hospitals, government hospitals, level 4 upwards, they are doing something called VIA and VILI. And they are screening for this cancer. There's no reason why a woman should wait not to be screened. They shouldn't get to where they are accidentally being found to have cancer. And even if that happens, it should be that they are found when it is early and when it's treatable. It is possible to prevent cancer cervix. That's the preaching I like to talk about, that it is possible. Unlike other cancers, cancer cervix, we do know exactly what causes it. So we can find out whether somebody has the causative organism. In 99.7% of the cancer cervix is caused by something called human papillomavirus. And it is, human papillomavirus is the commonest sexually transmitted infection. And in a lifetime, about 70 to 80% of women will acquire human papillomavirus. And if that happens to persist, then it's going to change their cervixes and other organs, even in men. So human papillomavirus is a bad thing. It should be screened for.